do, again, is retaining the water only, okay, and diluting the sodium. The urine also will be concentrated, right? So therefore, the specific gravity, the urine will be elevated. The urine sodium will be elevated because that urine osmolality also is elevated, right? Yes or no? So when you compare it with diabetes insipidus, the patient is putting out plenty amounts of hypotonic water through the urine. So therefore, that the urine is diluted, therefore the specific gravity is low, therefore the urine sodium is low, therefore the urine osmolality is low. Okay. So now let's do the other part. So since your brains are fatigued, let's do hypernatremia, and then I will leave, which is a very easy topic, potassium and calcium and phosphorus, which is electrolytes. You have a video done by me, so you have to watch that video independently. Okay? It's not a difficult topic. Okay, so since we love algorithm, you have another algorithm for hypernatremia that you were also exposed in the past. So here, in patients with hypernatremia, there's no reason to take into account the osmolality because it makes sense that the patient with hypernatremia always would have elevated osmolality. Sodium controls osmolarity, and if the sodium is elevated, even though there's other solutes in plasma that will have a higher osmolality than sodium, that's not going to affect the value of the osmolality. So therefore, in hypernatremia, there's no concern about knowing how much is the osmolality because it will always be elevated. Okay? So what you need to be concerned about is, let me open up a different algorithm, which is easier to understand. You have this one in your Merck manual, and you have this one in your Harrison's. So the one that is easier to understand is this algorithm, okay? Why? Because remember that the next step after osmolality in hyponatremia, we talked about how is the volume status of the patient, right? How is that extracellular fluid compartment? Because when you draw blood on a patient, that's from the ACF, right? So first of all, you need to know if the patient is in not a hyper all smaller state or hypovolemic state that we discussed in hypernatremia, but how is the ECF compartment for that patient that has hypernatremia? Is it concentrated? Because I am giving a treatment. Remember that many times, the same way as type 1 hyperthyroidism, you know that if the patient is hypothyroid, when you give levothyroxine, the patient can become hyper. The same way in hypernatremia, when you treat hyponatremia, the treatment itself can provoke a hyperosmolar state, and therefore the ECF compartment will have an elevated sodium and an elevated osmolality, even though it's your purpose, because when you give a patient 3% saline, when you give a patient mannitol, your purpose is to increase the osmolality of that ECF compartment. Do you understand? So when you draw sodium on a patient and you have a sodium level of 150, okay, might be because you're giving a treatment to the patient as mannitol or 3% saline or sodium bicarbonate to be able to elevate that sodium and provoke a shift, right, of fluid from the ICF, from the brain cells, outside to the ECF compartment. Do you understand? So the most common cause of hypernatremia, okay, of course, with an ECF compartment concentrated, is due to treatment of hyponatremia. So as you can see here, this patient has a hypervolemic state, an ECF that is increased in osmolality because you are giving the patient either 3% or sodium tabs, the tablets. You're giving the patient hypertonic sodium chloride, 3%. You're giving a patient mannitol, or you're giving a patient sodium bicarbonate. That's the easiest. And you can see it because this is the patient that comes in with brain trauma or a stroke with cerebral edema, and you're giving a patient mannitol, and the only thing that you have to do is to check the serum osmolality and maintain the serum osmolality elevated, which it will be, how much? More than what? 300. More than 300, but less than 320. Because your expected value, your goal value, is to maintain the serum osmolality between 300 to 320. When it overpasses 320, it's dangerous because you can provoke so much fluid shift, okay, that brain cell can shrink to the point of provoking pontine melanosis, okay, which is a major complication of cerebral paralysis. Okay, you have to avoid that. The same way with 3% saline, your goal for sodium, when you check the sodium every 4 or every 6 hours, depending on your hospital protocol, you need to maintain the sodium between 145 to 155, no more than that. Because if you shift greater than 155, or even faster, right, than 12 milliequivalents, do you remember that? In 24 hours, right? Or how much? 20?
No, it's less than 18 and 48.
Then you can provoke pontine melanosis. Okay? So that is one part of the algorithm and the easiest. You know that the patient was in metabolic acidosis or the patient went into cardiac arrest, and you have given already 2 amps, 3 amps of sodium bicarbonate during the ACLS or cardiac arrest protocol. You understand? Or you have given mannitol in the OR before the patient went to craniotomy because of or craniectomy due to cerebral edema, etc. That's the easiest on the part. Okay? Then you have the same 2 possibilities as you had in hypernatremia. Is the patient dehydrated, or is the patient euvolemic? So, is the patient hypovolemic, which is the hypotonic fluid deficit, okay? Same thing as saying my patient's dehydrated. When the patients have flat neck veins, when the patients have dry mucous membrane or skin, right? When the patients have elevated BUN and creatinine, these are the patients that are dehydrated. And what was the question that you were asking yourself to know if it's coming from extrarenal or renal? Was it the sodium level? Well, look at the sodium level. Remember that I told you that if it's diarrhea, if it's vomiting, if it's massive sweating, the sodium level will be normal, right? And if it's related to either diuretics or renal problems, the sodium level will be elevated. Do you understand? Now, if you want to look at the serum osmolality, okay, remember that the patients, when the patients are dehydrated due to non-renal conditions, okay, the normal nature of the autoregulatory state is to conserve not only sodium in plasma, but also conserve water. So yes, because it's extra-renal, you do not lose sodium in the urine, but your urine osmolality will be high. Do you understand? If it's related to a renal condition, because you're giving diuretics and you're straining that sodium to come out, that sodium will be elevated in urine. But remember that if you have renal failure, or if you are a patient that is in diuretic, the conservation of water at the level of the tubules will be impeded. Therefore, the urine osmolality of those patients will be low. Okay? But I want you to, if the urine osmolality is what actually throws you off, concentrate only on the sodium, and you will get it. Okay? Remember again, the only reasons to excrete sodium in the urine is you're giving diuretics, you have renal failure, or you have an autoimmune condition that could be related or not, with ADH and aldosterone. All right? Now, remember that in hyponatremia, we discussed it before the test, right? Remember that in hyponatremia, euvolemic state, meaning that the patient has no dehydration, no volume overload, you had two possibilities. Remember that one part was ASI-ADH, right? And the other part was polydipsia. Here is the opposite. Well, one part is diabetes insipidus, and the other part is hypodipsia. You're not consuming normal amount of water, right? So who do you think will not consume normal amount of water? Either you or me that are working constantly and you forget to eat or drink,
Yes.
or the elderly patient that their osmotic receptors, their perception receptors are impeded already. They don't feel the need to drink water, right? Or again, us. This is my first bottle of water in this day because he brought it to me. I was already feeling thirsty, but I normally forget, as you forget. You just keep going and going and doing, and you don't drink water, you don't urinate, right? And that's where the problems come. So let's talk about diabetes insipidus. What is diabetes insipidus? Remember that you have three types of diabetes insipidus, right? First, psychogenic diabetes insipidus, that this doesn't apply in hypernatremia. Why? Because that's the obsessive compulsive person that is drinking too much water. And drinking too much water is polydipsia. And polydipsia belongs to hyponatremia. Right? So therefore, my two other possibilities of diabetes insipidus that apply for the hypernatremia algorithm or patient is the nephrogenic diabetes insipidus or the central diabetes insipidus. If you're born genetically with deficit of vasopressin, which is anti-diuretic hormone, what happens is that when you are either in hypovolemic state or hypotensive state, remember the algorithm that you control volume and pressure with your catecholamines, renin-angiotensin, aldosterone system, and at the end vasopressin? Well, that's not going to work. So instead of you trying to retain water at the end of the autoregulatory state, you can't. And for the contrary, you now lose the conservation of water. So now you're excreting large amounts of water only in the urine. So imagine yourself putting out gallons and gallons of only water in the urine and not solutes, not electrolytes. That means that not only your urine sodium in the urine will be low, but in addition to that, your osmolality in the urine will also be low because osmolality is no more than the ratio proportion of solutes and water. So since you only urinate water, tap water, okay, your urine sodium in the urine will be low. Even if it's not there, it's the truth, okay? Your urine osmolality will be low. Your urine specific gravity will be low. But you're losing only water, so where's your electrolyte? Retaining plasma. And that's the reason why your plasma sodium will be elevated. And not only that, your serum osmo will also be elevated. So you would have hypernatremia with hyperosmolality, right? In plasma. Yes or no?
Yes.
Okay. So let's analyze this here. Again, this is the euvolemic patient. Okay? So this is the hypernatremic patient that when you assess that patient and when you look at the BUN of that patient, it's normal. It's a euvolemic patient. I understand that as the disease progresses and there's no treatment, because it hasn't been recognized, or the patient is non-compliant to treatment, the patient is going to be dehydrated at the end. I know that. But unfortunately, in medicine, you have to know the initial stages. And the initial stages of diabetes insipidus is a eubulimic state. Okay? Why? Because you only lose pure water. All right? You're losing pure water because you either centrally are deficient of ADH, either by congenitally being born like that or having a brain trauma, right, into the posterior hypophysis, or nephrogenically because you lack or your resistance to the aquaporin receptors for the ADH, and therefore the patients cannot conserve water. They lose water, okay? So, again, when you have a patient with hypernatremia that is eubulimic, that you see that the patient is urinating almost 6 liters of fluid in the urine, okay? So you can do 2 things. First, of course your serum osmolality will be elevated in a patient with hypernatremic state. The next step is to check what? Let me go to my urine. And in the urine, let me check the urine osmol. If the urine osmol is low, less than 700. If the urine sodium is low, which it will be less than 20, right? Yes or no?
Yes.
And if your urine osmolality is low, which it will be less than 1.0, 10 to 20, remember? That's the normal value. If that is less than 1.010, you have a low urine osmolality and you have diabetes insipidus. But if, for the contrary, you have a patient with hypernatremia and it's eubulimic and the urine sodium, even though it's not reflected here, okay, is conserved still. So if it's conserved and it's still low because I don't have diuretic, I don't have renal failure, I don't have an autoimmune condition right here, how can you differentiate diabetes insipidus with a conservation of urine sodium and hypodipsia as well with a normal urine sodium? Check the urine osmol and specific gravity. If you're not drinking enough water, your urine will be concentrated, therefore your urine specific gravity in hypodipsia will be high, and the urine osmolality therefore will be high compared to DI. Do you understand? Why I'm not taking into account the urine sodium here? Because both will be normal. Both will be low. And that's the reason why it's not placed in this algorithm. Do I say it again? Yes. All right. Patient comes with a sodium level of 161. The patient had a traumatic brain injury after motor vehicle accident. The patient CT scan of the brain shows that there is significant intracerebral hemorrhage occupying the third ventricle and with midline shift and cerebroedema. The patient goes to the OR and mannitol 500 ml were given before surgery.
You're gonna do
What part of the algorithm is that? What are you going to do? Nothing. Nothing. If your serum osmolality is 315, nothing. That's the expectation. Do you understand? That will be one example of a question. My patient has sodium level of 159, okay? And my patient has been vomiting for the past 3 days after travel to a third world country. The mucous membranes are dry. BUN is 29. What's the next question that you have to ask me? Or let me ask you a question. Tell me, how would you expect the urine sodium to be on this patient?
hyper.
right? Dehydrated, vomiting. Yes? So I expect that my urine sodium will be low because it's extra renal. Okay? I have a patient again that had a traumatic brain injury. Tell me the causes of diabetes insipidus. Tell me the causes of ASIADH.
Trauma.
Brain first, right? Brain problems, so brain trauma, brain tumors, a stroke.
Lung cancer.
Second, lung problems. Number one, small cell carcinoma of the lung. You had that with me and endocrine. But on top of that, any lung problem, from pneumonia to asthma to bronchiectasis to any lung problem. Could it be medications? Of course. Which medications?
Diuretic.
From chemotherapy to diuretics. Let me show you. You have it in your slide. Doesn't matter who taught it. You had it already. Right here. Carcinomas, pulmonary disorders, central nervous system disorders, medications, malignancies, idiopathic. Let's go. Look at how many problems can give you ASIADH. Leading number one, lung cancer. But as you can see, any lung problem. You think about a lung problem, they can give you ASIADH. So the patient now comes in with pneumonia, okay, even though sepsis can give you shifting, right, of fluid. Yes or no? There's a major redistribution of fluid when the patient has sepsis. And you can have hypernatremia, you have redistribution of fluid and being dehydrated because the patient is septic. Don't you give a bolus of fluid every time you call sepsis? Right? But pneumonia can also give you hypernatremia with a euvolemic state due to syndrome of inappropriate antidiuretic hormone. And the only way that you know how to differentiate ASIADH versus that my patient is dehydrated, even though I don't see signs and symptoms of dehydration yet, is to do what? Not only serum osmolality, but to do urine sodium, right? To do urine osmo, and to do specific gravity. And you expect that if your patient has hypernatremia due to dehydration, due to the sepsis, the urine sodium will be low. Versus if I have ASIADH, my urine sodium will be high. Okay? Even though this is a nephro call, because when we have hyponatremia, unfortunately, we call nephro, but you need to know it as well. Okay? So as I told you, from asthma to anything in the lung, anything that you can imagine. Why? Because ADH is not only released in the posterior hypophysis, but we also release in the lung antidiuretic hormone.
I just don't understand, if you have a pure water deficit, how can you be able to?
Okay, because as I told you, there is only water brought it into the plasma, but not in the interstitium. Okay, do you remember that we have intracellular fluid and extracellular fluid?
Yes.
And the extracellular fluid is divided into plasma and interstitium. Okay, so yes, you have the volume in the ECF, but you have it in plasma. You don't have it in the interstitium where you have third space indeed. Okay, that's why it's so well redistributed that the electrolytes are in both compartments, for the water excess is in the plasma compartment and not in the interstitium, and that's why it's called euvolemic. Even though you restrict water as part of the treatment for ASIADH. You understand? But you don't see the pitting edema on the patient. because it's in plasma, it's not in the interstitial. All right? Yes, it's a little confusing. Okay? So, but if we come here, not only traumatic brain injuries, not only stroke, not only brain tumors, but if you have anything in your brain, from meningitis, encephalitis, any infectious process, can also give you syndrome of inappropriate antidiuretic hormone. All right? Now, since we're here, even though it is in the back of the algorithm, how do you treat syndrome of inappropriate diuretic hormone? Leading number one, fluid restriction. What else? How do you block vasopressin? Well, vasopressin can be blocked by giving antagonists of vasopressors, right? So who blocks vasopressin? Not only conivactin and tolvaptan, which are medications that you had in endocrine and neuro, to be able to block vasopressin, but also the meclocycline, which is a family of the tetracycline that, as an off-label indication, they do block vasopressin as well. Okay? So again, going back to the algorithm again. So you have a patient right now that had meningitis, okay? And my laboratory results are sodium is 158, zero osmolality is 340, okay? First of all, with the history of meningitis and hypernatremia, which diseases process are you trying to rule out? Are you going to try to rule out possibility that I gave you mannitol, 3% saline, and sodium bicarbonate? No, right? Are you really believe that this patient with meningitis, even though meningitis is an infectious process and the patient can be septic? Yes, okay? But my first number one disease process that I have in mind is, do I have diabetes insipidus, right? And if I do have diabetes insipidus, compared to the dehydration state of the sepsis, what are you going to look at first? Let me see my urine osmolality, right? If my patient urine osmolality is high, that patient is conserving water. So that means that my patient is septic. Do you understand? But on top of that, the urine sodium will be low, right? So my point of comparison cannot be the urine sodium, because if a patient has an extra renal cause of dehydration, my urine sodium will be low. But my urine osmolality will be high, because my urine is concentrated. Guys, when you're dehydrated, your urine is concentrated. You're looking at me like if I have two heads. Right? But if I have diabetes insipidus, not only my dehydrated patient will not have a good urine output, but my patient with diabetes insipidus would have a plenty urine output. You find yourself dumping the bags of urine. Crystal clear urine, okay? When you measure serum osmol in a patient that is dehydrated, it's high, but the urine osmol is high, and the urine sodium is low. Diabetes insipidus, yes, hypernatremia, hyperosmolar in plasma, but the urine osmolality will be low, going down. Why? Because it's crystal clear urine, hypotonic urine, no solutes. Guys, osmolality is the proportion of solutes versus water. If you are urinating plenty of water, how's gonna be your urine osmol? Low, less than 700. But if you measure the urine sodium, even though it's diabetes insipidus, which you're saying, well, but you told me that if I have an autoimmune condition that could include ADH or aldosterone, my urine sodium has to be high. Not in this case, because my patient is urinating plenty amount of water, diluting that sodium that normally drops in the urine. So you have to guide yourself through urine osmolality. Okay? So, hypernatremia, of course it's gonna have a hyperosmolality. Are you treating me with sodium bicarbonate because I just went into cardiac arrest, or you're giving me sodium bicarbonate because I have salicylate toxicity and you're trying to alkalinize the urine? Okay, that's fine, leave him alone. Leave the patient alone, unless the serum osmol goes greater than 320. That's when you have to stop that treatment, okay? Or are you giving me 3% saline, but your sodium goal remains between 145 and 155? That's what I want to decrease the cerebral edema. Leave the patient alone. That's your purpose. Or if you see that that patient went to surgery, your first question when you receive report from a patient coming from the OR, did the patient receive mannitol? Why? Because you're going to do serum osmolality to check, and you need to know if it was given or not. All right? Doesn't mean that you're going to treat it. You're not going to reverse that. You're just not going to give another dose if the next lab test comes high, greater than 320. Right? You have a hypernatremic patient. Look at the volume status of the patient. Is the patient dehydrated? Same question you had in hyponatremia. If my patient is dehydrated, then what do I have to care about next? Urine sodium, right? If my patient is dehydrated because my patient is vomiting, having diarrhea, sweating, any type of hemorrhage, any type of dehydration other than kidney. And when I say kidney, I say diuretics. Do you remember? The only ways to have high sodium in the urine is diuretics, renal failure, or an autoimmune condition that could include ADH or aldosterone. So if my urine sodium is elevated, greater than 20, diuretics. You're giving me Lasix, hydrochlorothiazide, you might be giving me aldactone, or maybe Diamox, right? But if my urine sodium is low, less than 20, in some books less than 10, but still normal, 10 to 20. What is it? My vomiting, my diarrhea, my sweating. If my patient has no dehydration signs, and you see my patient uremic, could it be that you're not drinking enough fluid? Or could it be DI? If you're not drinking enough fluid, of course you're going to be conserving water. Therefore, your urine osmolality will be greater than 700. But if you have diabetes insipidus, not only you will be peeing your water out, but water, no sodium. Therefore, your urine osmolality will be less than 2. Okay? Any questions? No? All right. So these are the stats, which I'm not going to read. All right? So, remember how you treat diabetes insipidus? Remember that in diabetes insipidus, the first question you have to ask yourself is, am I diluting? And that's the reason why I have this values, restrict the water. Most likely in a female, and even though nowadays, even the guys bring the bottles, right, with them, restrict the water and see if your urine sodium, your urine osmolality, your specific gravity gets corrected after 4 hours. All this have to be in a very high controlled environment. If you're suspecting ADH or diabetes insipidus, that patient must be either in a step-down unit or in ICU. because any major shift of sodium, therefore water, can provoke on-time myelolysis, right? So if that doesn't work, the most common after that will be central diabetes insipidus. And to be able to rule that out, you're gonna give the patient desmopressin, right? GGABP. And if it doesn't work, how do you know it doesn't work? Again, after 4 hours, you're gonna be measuring again your sodium in plasma, your serum osmo in plasma, your urine osmo, your urine osmolality, and your urine sodium. And if that improves, that means that the patient has central diabetes insipidus. And you have to do a CAT scan, right, of the brain to look for a tumor, which a pituitary tumor is the most common. Even though it could be traumatic brain injury, strokes, etc. Okay? And if that doesn't work, what else can you do? Well, most likely I have a nephrogenic diabetes insipidus. That means that you have to give a medication to improve the receptors, sensitivity. And believe it or not, diuretics are the leading cause, are the leading treatment for that. Because when you give a diuretic, what are you doing? You're forcing what? Sodium to come out, right? So you are basically equalizing compartment. You're provoking that homeostasis, that balance. You force the sodium to come out, and if you force the sodium to come out from plasma to the urine, not only you will equalize compartment at the level of the urine, because not only you put out volume, but you also put out sodium, but you also equalize electrolytes and water in plasma as well. So you're forcing the outer regulatory state, okay? So again, you have a patient with polyuria. As I told you, these patients urinate a lot, and I'm talking about more than 3 liters of fluid, hypotonic. You look at the urine, and if you see the urine yellow, that's not DI. You can test whatever you want, but for sure, it's not gonna be DI. It could be the salt wasting syndrome, but it would never be diabetes insipidus. The diabetes insipidus, you have water diuresis, okay? And as I told you, you believe that the patient has diabetes insipidus. You don't know if it's central, you don't know if it's nephrogenic, you don't know if it's dipsogenic or psychogenic. The first step is to restrict the water, okay? And if that doesn't work, then what's gonna happen later? Well, I believe that the most common cause is central. Give the DDAVP. And if it works, you treat the patient, right? And you look for possible cause. And you remove that cause if this is a pituitary tumor. Otherwise, if it's nephrogenic, okay, what you would do is, again, diuretics, okay? As you can see, patients, for example, if they have any type of chronic kidney injury, the aquaporins could be affected, okay? So basically the sensitivity of the receptors could be affected. Now, in addition to that, the best way, even though you could do the sodium spot and the specific gravity in the urine and the urine osmolality, okay, separated, the best way is to actually do a 24-hour urine collection, okay, for those patients. And as you can see, this is just broken down, okay, the same way as I told you in the algorithm. When you have a patient with hypernatremia, your next question is, how's the volume status of the patient? Does the patient have volume expansion? Meaning that the ECF has sodium bicarbonate, has 3% saline, has mannitol, sodium tabs that you're giving to the patient. Well, that's expected. If I'm in the goal of treatment, leave the patient alone. Do I have volume depletion? Meaning that I'm dehydrated. And if I'm dehydrated, I'm dehydrated because of extrarenal causes, vomiting, diarrhea, sweating, etc. Or I'm dehydrating the patient because I'm giving diuretic. How do I know that? Look at the urine sodium. Vomiting, normal urine sodium, less than 20. Patient with diuretics, urine sodium elevated, more than 20, right? Is the patient euvolemic? Is my patient euvolemic but hypernatremic because it's not consuming normal amount of water? Give the water. look for the parameters. But this is not gonna be happening on the patient that you see that had an injury on the brain, that had encephalitis, or a patient that had a stroke, that you're suspecting diabetes insipidus, and you see that the patient is urinating and you're dumping the bags of urine. The first disease process that you're gonna suspect is diabetes insipidus, right? And how can you differentiate, again, diabetes insipidus from salt wasting syndrome that the patient also has polyuria? Urine osmolality. My patient in salt wasting syndrome, the word is telling you salt wasting syndrome. The patient is dumping large amounts of sodium in the urine, therefore the osmolality is high, even though the amount of urine is large. Compared to diabetes insipidus, that this water, hypotonic urine, is being taken out, therefore the urine sodium is low in the urine, therefore the urine osmolality is low in the urine, as well as the specific gravity, even though the causes could be the same.
Could we just then look at the urine sodium when we start with? I know that's what's always been, but would that be sufficient to differentiate
Between what?
the salt wasting with
Versus DI?
Yeah.
Yes.
with the urine sodium.
Okay? So, do you remember how we treat SIADH? Didn't we say restriction of fluid? Didn't we say demeclocycline, a family of tetracycline, because inhibits vasopressin, right? What is the cause for diabetes insipidus? A cause for one is the treatment for the other. The treatment for one is the cause of the other. Okay? Yes, I had a question.
The cerebral salt wasting, the serum osmolality would be like
Hi, yes, well.
high as well. Even though you're throwing out all this sodium, where's all the sodium coming from? If you're just getting rid of it, the brain is making it.
It's not making it, it's shifting it.
Oh, it's taking it out.
It's shifting it because of thyroid D. Okay? So look how many medications can provoke a diuresis state, okay? But of the hypotonic, large hypotonic amount of fluid coming out, okay? And therefore can provoke as well nephrogenic diabetes insipidus. From alcohol, remember that alcohol was a cause of hypernatremia as well, okay? Remember last week somebody told me, but isn't dehydration give you hypernatremia? Well, dehydration can also give you hyponatremia and hypernatremia, right? So even though alcohol, binging, beer, basically is an inhibitor not only of aldosterone but also ADH, and most likely what happens is that you're going to the bathroom to put large amounts of water only, okay? Most likely alcohol, most commonly alcohol is the cause of hyponatremia, but in a later stages the patients can be dehydrated and hyponatremic. I'm not gonna ask you like that yet, because otherwise it's too much, okay? Lithium. Lithium is a cause for diabetes insipidus as well, okay? And many other diuretics. And if you look, Levofet, Liburide, how many medications can give you a diuretic state and nephrogenic diabetes insipidus? Okay? And if we keep talking, remember that the same causes, brain causes of SIADH can be the causes of diabetes insipidus as well. It's just a cause, but the clinical state is different, okay? You can have traumatic brain injury and brain tumor and encephalitis and meningitis and Guillain-Barré and multiple sclerosis and have SIADH or diabetes insipidus, okay? How do I know? Well, depending on, look at the patient. Is the patient urinating a large amount of water? Most likely it's DI, right? Also wasting syndrome compared to SIADH, that an SIADH patient will be oliguric, all right? In addition to that, do you remember that I told you that not diabetes insipidus itself, but in the algorithm of hypernatremia, we have the hypodictic state, right? So the patient is not consuming the normal amount of water. And why? Why? Because you and me forget, or The elderly doesn't forget, but the problem is that the thirst perception is impaired, okay? So most commonly patients that are either bedbound or in traction because of trauma, or that there's no normal attention, right? A nursing care, and they're not giving the actual water because they will actually forget to drink it, okay? And as you can see, there's plenty of causes of hypernatremia due to diabetes insipidus as well. So as I told you, you have central and nephrogenic diabetes insipidus. The central diabetes insipidus most likely is related to patients not secreting. Think about diabetes mellitus. The diabetes type 1, either you congenitally were born with deficit of insulin, or you have pancreatitis or pancreatic tumors, and therefore you also lost the ability of secrete insulin. Exactly the same way in central. You could even have a traumatic brain injury and you acquired that deficit of secreting ADH, or you were born genetically with a deficit of ADH, and therefore, remember, anti-diuretic hormone, so that means that you will conserve the water in cases of hypovolemia or hypotension. And that patient cannot do that because they have deficit of anti-diuresis. So therefore, they will diurese, okay? And plenty amount of hypotonic fluid, okay? So, as I told you, the first step is to try to conserve that water, restricting the water to the patient, okay? If it's a traumatic brain injury, you're not gonna think about dipsogenic diabetes insipidus, right? You have plenty of cause and evidence that this will be central, okay? Do you understand? You only restrict water on a diabetes insipidus patient if now you come to me and you have a patient urinating 4 liters of urine, completely crystal clear, and I have no idea why. And you have hypernatremia. Well, because she's the young lady, and the most common way of conducting youngsters is to drink and drink and drink and drink water because of beauty or skin texture or whatever, or losing weight or whatever you can tell about water, is to restrict the water. But if she now comes in and I do a CAT scan and I see a brain tumor, I'm not gonna restrict the water from her, right? Because most likely this is central diabetes insipidus. I have an evidence, I have a cause, all right? And instead, first of all, yes, you're gonna take the tumor away, right? But what else are you going to do? How are you gonna treat diabetes insipidus? Give the DPAVP. Even though you still give sodium chloride because that patient eventually will be dehydrated. Okay? So here you have the dosages, even though I'm not going to ask you the dosages, okay? What else can you give? Well, you can give a patient chlorpropamide, you can give a patient Tegretol. For the diabetes insipidus that is nephrogenic, remember that, what do you have at the level of the tubule? Well, I have in the proximal tubule angiotensin converting enzyme, right? I have in the posterior arterial prostaglandin, right? I have at the distal tubule, what do you have? Aldosterone, right? And I have in the convolute ADH, right? So let me target all those. So I can give thiazide diuretics that they act at the level of the proximal and distal, right? Proximal and distal. So what do they do? Reabsorption of sodium and chloride at the level of those tubules to be able to excrete sodium in addition to the water. So I can equalize compartment, okay? What else can you give? Well, let me block the prostaglandin at the level of the posterior arteriole of the nephron. So if you do that, not only you will inhibit prostaglandin, but you would also inhibit what? Aldosterone, right? Yes? And therefore, you would increase the levels of ADH. Another thing that you can do is give an antiarrhythmic Because this antiarrhythmic, basically what it does is provide lithium, other than with the tube. But the first initial treatment for diabetes insipidus nephrogenic is giving thiazide diuretic, okay? And we went through the causes already, and the treatment. Okay, so first of all, how many causes of hypernatremia do I have? One, that I have a volume expansion. I'm not going to touch those patients because my purpose is to give mannitol 3% saline or sodium bicarbonate according to the etiology that the patient would have, right? So what do I have to do with the rest? My patient's dehydrated. Do you really believe that I'm going to give half normal saline, a quarter of normal saline, D5W, which are hypotonic solutions that they do not go among compartments equally on a patient that is dehydrated? No. If my patient has vomiting, diarrhea, sweating, hemorrhagic shock, I am going to give sodium chloride or LR and watch my patient. Are the clinical signs and symptoms improved? Is my sodium the next day in plasma improved? Do you understand? If it doesn't improve and is worse, what do you think I would do next? Then I will switch the sodium chloride or LR into my hypotonic solutions, which my next step would be either 0.45 normal saline, right? Or a quarter of normal saline. Or if those don't work, I can go to my even highest hypotonic substance, which is D5W. Do you understand? If you're dehydrated, if you have signs and symptoms of dehydration, you have to give fluids. Isotonic fluids. Do not start with D5W or hypotonic substances if there's clinical evidence of dehydration. If the dehydration state is because you're giving a patient diuretics, hold it or decrease the dose and give fluids to the patient. Isotonic fluids.
Oh wait, if you switch later on to the hypotonic, you're pushing it in the cell, so you're putting the patient more hypovolemic.
But honey, if now I'm giving sodium chloride and your hypernatremic status doesn't improve, this is a trial and error. What I have to do, let me try to switch them. But if you see the next day the laboratory values are better, just keep it, and the sodium will be corrected. Do you understand? It's the same as if you look at the algorithm, open the bottom of your hypernatremia algorithm, and I'll open mine. So you can see that it's a trial and error, and I did not invent this. What does it say here? It says, for mild symptoms of hypernatremia or asymptomatic patients with a serum sodium above 125, use conservative approach. Listen to this. Water restriction first. But can I restrict the water if I'm dehydrated? No. Listen, water restriction. If the serum sodium continues to decline, then I'm not going to restrict the water. What I'm going to do instead is what? Hydrate the patient. Listen. May be given to clarify the diagnosis. If the patient has ASIADH, for sure it's going to be worse. If you give the fluid, the ASIADH patients and the sodium level in plasma is going to be worse. What do you have to do then? Hold it, restrict. That's women. Well, you have to do something meanwhile you get laboratory results, right? Yes or no?
Yeah.
If you don't see the clinical evidence of dehydration, the clinical evidence of euvolemic state, or the clinical evidence of volume overload, you have to do a trial and error. That's what happens in clinical practice. Unfortunately, you're never going to be tested like that because nobody can answer properly in any test. You have to give me the values for me to respond appropriately. But in clinical practice, if you don't have the sodium level in urine yet, if you don't have the urine osmolality yet, what are you going to do? Trial and error. And the trial and error in hypernatremia is the same. Well, if I see the clinical evidence of dehydration, I'm going to give the sodium chloride or LR. But what do the majority of practitioners do when they see hypernatremia? Have normal saline, D5W. And what do you do next? If the patient next day is worse, hold it, LR, or sodium chloride, because they don't have the values yet. And that's normal practice. That is actually what has to be done until you receive the values, okay? Any question? No? So as you could see, as a general understanding, and I don't want you to get confused because it's actually the way you ask. If I ask you in general, what would be the best solution to treat hypernatremia, you would answer hypotonic solutions, as you had one question, right? And the hypotonic solutions are half normal saline, which is 0.45, or a quarter of normal saline, or D5W, right? But if I'm giving you evidence of dehydration, you would never do that. You hydrate the patient first, and the best solution for hydration is normal saline or LR, right? So you replace as calculation that you learned, right? How to replace fluid and maintenance fluid. And of course, you're going to check neurological status of your patient, right? Because if the patient is completely normal, you have time to replace. All right? And you continue checking the serum sodium. We normally do it when it's critical level every 4 hours. In some other institutions, every 6 hours, okay? So we went over already. So central diabetes insipidus, you give TDADP. Nephrogenic diabetes insipidus, yes, you decrease the sodium intake, but in addition to that, you would give thiazide diuretics, which is the first initial step, or the best step to treat. Okay? So we have a 47-year-old Caucasian admitted with 3 days history of shortness of breath, weakness, anorexia, and unsteady gait, including a recent fall. Okay? Patient had a medical history significant for peptic ulcer disease and hypertension. His family history was non-significant. He reported smoking 2 packs per day and drinking 8 to 12 beers per day for the past 20 years. On physical exam, the patient has bilateral pitting edema above the knees and crackles, as well as dullness to percussion in the left lower lobe. What do I have? Signs and symptoms of? Fluid overload. And I have a lung problem there too, right? Smoking. All right? In addition, chest radiograph revealed left lower lobe pneumonia, significant laboratory results, the WBC 19,000, plasma osmo is 258, and the sodium is 105. So far, guys, I know it's hypo, going back to the cases, right? Pitting edema. So I have a hyponatremia with low osmolality, with a low VUN, with signs and symptoms of volume overload. What are my choices? My choices are CHF, cirrhosis, nephrotic syndrome, or renal failure. What do I need to know? Urine sodium. My urine sodium high is renal failure. My urine sodium is low, is CHF, nephrotic syndrome, cirrhosis of the liver. And my urine sodium is less than 10. So that patient has pulmonary edema, most likely related to pneumonia. So what do I have to do? Echo. And most likely, diuretics. And you have the algorithm. 75-year-old female, hypertension, COPD, antihypertensive treatment, bronchodilators and multivitamin because of inadequate control of blood pressure. I guess hydrochlorothiazide was given. She was admitted with chest pain, vomiting, and loss of consciousness. On examination, she was afebrile, oriented or drowsy. Heart rate is 48, blood pressure is 100/60. was no pallor, cyanosis, clotting, pitting edema, and JVD was not raised. What am I telling you? That even though my patient is in thiazide diuretics and he was vomiting, I don't see any signs and symptoms of what? Dehydration, right? No pitting edema, no JVD. Euvolemic, right? So far so good? All right, sodium 110, potassium 2.6, plasma osmolality is 262. So hyponatremia, hypoosmolar, euvolemic, even though I'm with hydrochlorothiazide. Listen, okay? That's the confusion factor there. So if I'm euvolemic, what are my choices? Do I have SIADH or do I have polydipsia? Most likely polydipsia is not going to be. Most likely will be SIADH. Why? Because certain medications, including diuretics, can induce SIADH or diabetes insipidus. Didn't I say yet? That cannot be diabetes insipidus at all. First of all, it's not hypernatremia. Second of all, hydrochlorothiazide is a treatment for it. Okay? So, even though my patient is euvolemic, my BUN is 38, right? But my urine sodium is 26 SIADH. If I now tell you BUN is 38, but I have signs and symptoms of dehydration here, what would it be? With a urine sodium of 26, diuretic induced. I have a cervical biopsy with a squamous cell cancer, endometrial biopsy, most likely invasive with metastasis. Sodium 154. I have cancer. Any cancer can give you what? Hypernatremia. DI. So potassium is 3.1, magnesium is 1.8, plasma osmo 261. That's obvious. I mean, it's going to be high anyways. Other lab tests show BUN 30, WBC 16. Urine specific gravity was found to be higher than, but still low. And urine osmo is decreased. Okay, if you see here higher than 1.0001, but still low, very low, it's 10 to 20. Okay, so the urine osmo is decreased. The specific gravity is decreased, and I have a cancer patient, diabetes insipidus. 62-year-old, history of lobectomy, squamous cell carcinoma. All right? Most likely what? It has to be SIADH. All right? But let's see if it's true. CT scan shows this and this and this and this and that. Let me see the values. Hyponatremia. Elevated urine osmo. Okay. Serum osmo is 255. So I have hyponatremia, hypoosmolar, normal BUN, but elevated urine concentration of sodium. So remember, when you have a patient with hyponatremia, hypoosmolar, and I'm thinking about SIADH because my patient has lung cancer, what state is that? Euvolemic, right? And I have two choices, SIADH or, polydipsia, right? The compulsive drinker or beer, yes? So how do I know it's SIADH? Because my urine sodium is elevated. How do I treat? Restrict the fluid, demeclocycline, or receptor antagonist for vasopressin, conivactin, otovactin. The Samska. And that's it. So